Hello everyone, I'm Bibata Wassonguema from Action contre la faim, and I will be presenting our study on the costing analysis of the integration of a simplified WASH kit in the Standard National Protocol for Treatment of Severe Acute Malnutrition in Northern Senegal. This costing analysis is performed as one of the steps of the economic evaluation of the TISA trial. I will start my presentation with an introduction on the TISA trial. We will then move on to presenting the costing analysis. TISA, Integrated Treatment of Acute Malnutrition, is a cluster randomized controlled trial trying to answer the following question. Can the addition of a simple household water treatment and agent promotion intervention to severe acute malnutrition outpatient therapeutic feeding program improve recovery? Subsidies of the trial include the effectiveness of the WASH intervention on recovery and nutritional status of some cases, the effectiveness of the WASH intervention on drinking water quality, the cost effectiveness, feasibility, and acceptability of the WASH intervention, and participants' exposure to enteric pathogens and antibiotic-resistant genes. The trial operational implementation was led by Action contre la faim Senegal, and the scientific direction is led by the LSHTM, the LARTES from Senegal, and ACF France. TISA RCT was randomized by health facility, comprising a control group receiving the standard severe acute malnutrition outpatient treatment and an intervention group receiving the standard outpatient treatment plus the TISA intervention. All the uncomplicated SAM cases aged 6 to 59 months and admitted at the outpatient treatment program were eligible for the study. The recruited participants were followed up for an 8-week period. The intervention consisted in delivering a WASH kit, a WASH package composed of soap, aqua tab, distributed weekly for an 8-week use, a safe water storage container with tap, and context-specific information and education communication. The agent promotion was made when giving the kit at admission and during 2 home visits by community health workers. About 1,720 SAM cases were recruited in 86 outpatient treatment facilities located in the north of Senegal in 2 departments, including 4 districts. The enrollment was completed in April last month, and the first results will be published this year. I will now proceed in presenting the costing analysis that aims to assess the cost of adding a WASH intervention to the standard Senegalese community management of acute malnutrition protocol to have the coming economic evaluation of the TISA trial. For this costing analysis, we focused on the children enrolled in the TISA intervention arm during the first year from January to December 2021. We follow the societal perspective to provide evidence for decision-making in the Senegalese context, taking into account the cost borne by all the stakeholders, including the health system, its partners, and the community. We perform the micro-costing analysis with ingredient-based approach to identify all the resources required as part of the intervention and estimate the associated cost. The unit cost include the TISA intervention cost and the cost related to SAM treatment, with the TISA intervention cost including the training of the health and community health workers cost, delivering the intervention, the cost related to promotion of adherence to SAM treatment, the cost of the WASH kit, and the cost related to agent promotion activities. The SAM treatment costs include the costs related to medical and nutritional treatment. We excluded all the costs not directly related to the intervention, which are costs related to research, monitoring, and supervision from ACF and LSHTM teams. Existing infrastructure costs were also excluded. We collected beneficiaries' cost and time data using a questionnaire administered at enrollment and patient clinical and Clinical data were retrieved from some management register that is completed at admission and during follow-up consultations. With observations and interviews performed with the health system and ACF staff, we were able to map all the activities and resources used as part of the intervention and to collect personnel time allocation data. For all the costs, we disaggregated costs into cost components that are material, human resources cost, and patient caregivers opportunity cost. For some treatment costs, additional cost components include costs related to drugs, ready-to-use therapeutic foods, patient transportation costs, and other out-of-pocket expenses. All the costs were expressed in 2021 international dollar using purchasing power parity exchange rate. The main outcome of the study was the cost per child treated with the adapted protocol and disaggregated by stakeholders that bear it. We performed sensitivity analysis to assess the uncertainty surrounding the cost estimation, including scenario analysis, a worst and best cases scenario, and the scenario of a TISA intervention being fully implemented by the healthcare system. The societal cost per child treated with the adapted protocol was $355, with the TISA intervention costing $117 and represents 33% of the total cost. In this cost, the past supported by the households was $58, representing 16% of the total cost. The rest was supported by the institutions, including SCF and the healthcare system. Let's now focus on the cost related to the wash kit distribution. On this graph, we can see that the cost of distributing a wash kit is not limited to the purchase cost of each of its components. This represents 69% of the total cost. The other costs include transport to distribution points, materials and human resources associated to sanitation for water treatment, the kit management cost, and the caregivers opportunity cost. In this table, we reported the results of a sensitivity analysis. We can see that the worst and best case scenario, which consisted in simultaneously changing all the study parameters across a range of plausible maximum and minimum values, shows that the cost of treating a SAM child with the adapted protocol can range from $255 to $518. Another scenario consisted in considering the intervention being fully implemented by the health system. This leads to the total cost increasing by only 1.4%. And this is because the TISA intervention fitted in as well as possible with the usual functioning of the healthcare system. The usual medical and nutritional treatment received by some children did not change, and the human resources used for the intervention were mostly those of the regular and community health system. The differences between the baseline analysis and this real-life scenario corresponds to the cost of training and distribution of the wash kits. For those both components, some components were facilitated by ACF and would cost slightly more in real life. This study is the first robust costing analysis of the integration of a wash treatment and hygiene promotion components in the community management of acute malnutrition in Senegal. The results will contribute towards the cost effectiveness evaluation of the TISA intervention if there is a significant difference in treatment outcomes between the two arms, and will support operational and policy decision making. I would like to thank all the contributors to this study. Thank you to all of you for your attention.